So I'm honored to introduce the last invited speaker, Dr. Anthony So. He's a distinguished professor of the practice at the Johns Hopkins Bloomberg School of Public Health and the founding director of the Innovation Design Enabling Access Initiative in the Department of International Health. The initiative also serves as the Secretariat for the Antibiotic Resistance Coalition, an alliance with over 20 civil society groups and the South Center. Professor So has served as co-convener of the UN Interagency Coordination Group on AMR and was part of the Antibiotic Resistance Working Group of the US President's Council of Advisors in Science and Technology. And he conducted research on reengineering how antibiotics are brought to market as a recipient of the Robert Wood Johnson Foundation Investigation Award in Health and Policy Research. And he was a co-lead author of the UN Environment Programme's Global Spotlight Report on the environmental dimension of AMR in 2023. So without further waiting, Dr. So, the floor is yours.
Thanks for the kind introduction, and to the organizers for the opportunity to share some reflections. When I accepted this invitation, little did I know I would end up opening the final day of this incredible conference, nor that I would actually follow also the presentation by Sabia Essek, which is both a remarkable opportunity to do so, her excellent presentation, but very sobering analysis, of course, of the poly crisis. And where some see, of course, a poly crisis, I see policy windows of opportunity. And while I cannot promise any lasting solutions for world peace, I hope I might suggest where we, and especially the EDAR community, can make a catalytic difference. The research I saw this past week was inspiring, and admittedly using approaches, very much beyond my training. But it was the beauty of it of us all coming together from different disciplinary perspectives to address a key part of the poly crisis. But how do we connect research success to policy significance? Let me begin with two conceptual frames. One is the idea of shaping and fitting and finding your place in the public narrative. Marshall Gantz of the Harvard Kennedy School of Government describes this from three vantage points: the story of self, which is a call to leadership; the story of us, which speaks to our shared values and experiences; and the story of now, which conveys strategy and action. The story of self gives purpose to the story of now, and vice versa. The story of self is connected to the story of us through community, and the story of now confers urgency to the story of us. At some point, these stories actually give rise to a theory of change. And by theory of change, I mean a clear hypothetical but causal roadmap, a proposition that if A happens, then B follows. And such a theory of change can help give us clarity to the vector of policy change we seek, not just magnitude, but also clear direction. Now, I believe that these stories are within each of us. And to the next generation of those in our room amidst us, the journey of the exciting careers ahead of you. For me, it began as a young Rockefeller Foundation program officer a couple decades ago. And it was a time when, in fact, of course, HIV/AIDS was a key part of the poly crisis. I found myself in the township of Kailicha on the outskirts of Cape Town, South Africa, talking to Zaki Ahmad, the founder of the then little-known Treatment Action Group, about the price of triple therapy for HIV/AIDS. They were, of course, Sabia mentioned earlier in the week, of course, subject to a lawsuit by 29 pharmaceutical companies against the government of Nelson Mandela over the Medicines Control Act. And in part, of course, that challenge was focused around the fact that HIV/AIDS triple therapy cost $10,000 to $15,000 per patient per year at that time, well beyond the means of most South Africans. And to ask people to undergo voluntary counseling without testing, without treatment, only promised them, of course, a lifetime of stigma. But there were 25 million people with HIV/AIDS at that time throughout the developing world. As luck would have it, my first grant at the Rockefeller Foundation was to a group, then known actually by the name of now known as by the name of Knowledge Ecology International. And they would go on to negotiate the entry of Cipla, an Indian generic company, to make available the first generic triple therapy combination for antiretrovirals at $350 per patient per year. And when I got that communication from London from the negotiations, I knew it was a game changer, because by lowering the price of hope from $10,000 to $15,000 to less than $1 a day, it no longer became possible for development aid agencies to turn a blind eye to this inequity. And the Global Fund for AIDS, TB, and malaria became possible. And that is a theory of change. But for me, actually, of course, that was, of course, something that, as a young, of course, program officer, I was only beginning to understand, of course, how does a policy actually work. And as in HIV/AIDS, the antibacterial R&D pipeline and how its end products were made available were a strategic starting point that helped galvanize policymaker attention. And so, of course, we endeavored, as you can see on the right-hand side of this slide, that if you wanted to change how, of course, global pharmaceutical innovation worked, it made sense to focus on where the business model did not. And for antibiotics, biology and economics actually were at odds. The more drugs one sells, of course, the more it drives resistance. And importantly, though, this was also true both in the global north and the global south. And that was, of course, important actually for when you actually want to pick a point of actually catalytic change. And so working with the EMA and ECDC, we then, as part of REACT, Action on Antibiotic Resistance, took a look at the known antibacterial drug candidates in the pipeline. And our analysis turned up the dearth of particularly those drugs targeting gram-negative pathogens. And the picture's not really significantly changed, even in more recent analyses by WHO, which had been carrying out, of course, such analyses more regularly of late. Now, part of the challenge, of course, was to bring, though, the concerns over antibiotic innovation into the larger discussions over innovation and access to medicines. In many ways, AMR was a vertical issue and in the backwaters of global health. At the WHO Consultative Expert Working Group on R&D Financing and Coordination, the concept of delinkage was gaining traction. And delinkage for them was a means of divorcing the funding of R&D from product pricing. The Consultative Expert Working Group described the idea. They envisioned that generic competition would bring pricing closer to marginal cost. They had, after all, just witnessed, in fact, HIV/AIDS medicines with entry of Cipla doing just that. And we figured out, well, maybe the idea could be exported. There were a number of folks who wanted to figure out, was there a way to create synergy between these two movements? And so the concept, of course, of delinkage could be, in fact, actually transported to antibiotic innovation circles. But it would also be different. It would divorce the return on investment from the sales volume or reimbursement. In other words, price times quantity, because in AMR, quantity matters. And today, of course, as Chantal Morel pointed out actually earlier in the week, delinkage is an important actually touchstone in the design of financial incentives. And whether or not actually, of course, we can shape the public narrative is the key here. And of course, this is again an example of how a concept actually then gets integrated into the public narrative. But however, such public narratives are not solo undertakings. It takes a village. And unlike published research articles, authorship of policy initiatives is and should be shared widely. But more importantly, it needs to be owned by the community. And sometimes you're fortunate enough to be in a position to help grow or nurture that community's vision. Again, at the Foundation, we use the ability to actually convene and create a shared agenda among government policymakers, researchers, and civil society, and to tap leading experts in the areas particularly that they were most concerned about in Southeast Asia, which were at the epidemiology and the economics of tobacco control. And we brought together people like John Sabat at Johns Hopkins at that time for epidemiology, Frank Chalupka at the University of Illinois Chicago, who was leading the World Bank's work on the economics of tobacco control, together. And we integrated the Rockefeller Foundation's funding with the Thailand's fledgling then, Health Promotion Foundation, the first such foundation actually that used an earmark tax on alcohol and tobacco to advance health promotion efforts in the developing world. And the Southeast Asia Tobacco Control Alliance was born, and in fact celebrated just a couple years ago its 20th anniversary. Now, many of the steps, of course, are the same elements you can probably hear in some of the discussions we heard this week. People putting together these kind of collaborations, building, in fact, the networks and community. And in fact, of course, that is what gives and empowers actually research. And I see much analogy, of course, to the important work of EDAR. And my hat's off to Ed Top and our colleagues leading up to Dominique Frigon, who have actually built this extraordinary community of research and practice. Taking a page from that of tobacco control, we anticipate that there would be a need to take an intersectoral approach, a One Health approach in tackling AMR. So a year ahead of the adoption of the global action plans on AMR by FAO, WHO, and WOA, in 2014, a group of civil society groups and the South Center, an intergovernmental think tank of 55 developing countries, came together to launch an intersectoral effort. This was recognition, of course, before actually the draft plan of the World Health Organization actually really integrated the One Health perspective. But for 10 years now, to this very month, the civil society groups and the intergovernmental actually think tank have discussed these issues, convened actually policymakers, worked with intergovernmental actually actors to actually try to actually give voice to civil society and also, of course, to the important efforts of those in low and middle income countries. Now, the story of now. How did we get to the story of now? Well, AMR was not always recognized as a key global health challenge. Back in 2001, the WHO put out policy guidance on the containment of AMR. But as luck would have it, they decided to launch it in the Washington Press Club on September 11th, 2001, one of the darkest days in US history. The press conference was canceled, and it took nearly a decade to resuscitate interest in AMR. Fast forward, the Swedish EU presidency in 2010 prioritized AMR. A transatlantic task force was born out of that. The UK review on AMR lifted attention globally to AMR. Margaret Chan, then Director General of the WHO, stood before the European Union and declared actually and warned of a post-antibiotic era. The global action plans on AMR were adopted in quick succession by WHO, FAO, and WOA in 2015. And by 2016, AMR had reached the UN General Assembly, becoming the fourth global health issue ever to be discussed actually before its chambers. It had earned its place among the polycrises. But what to do about it? The UNGA, or UN General Assembly High-Level Political Declaration on AMR, called for an Interagency Coordination Group on AMR, or IACG. And a group of us had the opportunity to present its recommendations to the UN Secretary General. Now, I don't make it a habit of speaking to the UN Secretary General, and I'm not very good at protocol or following it. So when the future of AMR global governance came up, of course, and discussion was being laid out, I just thought it was good to suggest that the UN Environment Program ought to be added. Of course, some of us were a little bit naive that actually it would take seed at all, but some of us also were keen on the UN Environment Program making the tripartite a quadripartite, both for the ministries and also the civil society movements that it engaged, and also for the opportunity that presented for us to strengthen the One Health response to AMR. Now, I'm not sure how much of this was ever really heard in actually at that time, but we took every opportunity to repeat the message, including using the social media, animated GIF you see on the left-hand side, through WHO, World Health Assembly briefings, and so on, that we truly need to be One Health, and for that, we need to be a quadripartite. And I'm deeply grateful to our UNEP colleagues, such as Echeverria, for bringing me together with Ed Top, David Graham, Amy Pruden, and Teresa Koch, as well as, of course, the glue that kept us all together, Susan von Gruters and others, all of whom, from which I learned so much and who graciously put up with me during the writing of the Bracing for Superbugs report. Now, when we started the report, UNEP was not yet a member of the quadripartite, but was in close working relationships with the tripartite. How could one shape the role of UNEP, both so that it gained internal buy-in and so that it was integral to the mission of this UN agency, but also that it be viewed as as a value-added partner to where the tripartite agencies already had considerable expertise. The Sustainable Development Goal of SDG 12, responsible consumption and production, is the one for which UNEP serves as the custodial agency, and it provides a core organizing focus for the environmental dimensions of AMR. The three economic value chains, pharmaceutical manufacturing, healthcare delivery, and also agri-food systems, all fall under the aegis of other international agencies. But the carrying capacity of each of these value chains is of systemic environmental concern. Overload a value chain with unnecessary use of antimicrobials, one might overwhelm the carrying capacity of the value chain, and as a result, spill over antimicrobials, ARGs, and yes, drug-resistant bacteria into the environment. Each of these value chains then opens the door, of course, to discussing the AMR-related pollution load that enters into the waste stream of the environment, as well as our municipal sewage systems that must be dealt with. And that falls within the remit of UNEP. Now, by value chain, I refer to the entire input-output process that brings a product or service from initial conception to the consumer's hands. In unpacking value chains, I'd like to begin with considering three flows through value chains: the flow of products, the flow of financing, and the flow of information. Across these value chains, one can find different points of intervention. And there may be choke points, such as when the US FDA decided to focus on actually asking for voluntary withdrawal of indications of antibiotic growth promotion from the 26 or so manufacturers of veterinary antimicrobials in the United States. But in Vietnam, the number of suppliers would have numbered in the hundreds. So local context matters as to where you actually intervene in the value chain. Or when the value chain crosses borders, and European Union restrictions on the antimicrobial residues on the imported shrimp can actually send, of course, ripple effects to Indian shrimp farmers who actually will change local practices in order to ensure their continued actually part and access of that actually export market. On the upper right, you can see many in the EDAR community can fit themselves in the research as researchers and their work in the systems approach to addressing AMR at the national and I would say even global level. And your work can also serve to help prime the policy triggers that our community and civil society can apply to, of course, advance and catalyze policy change. I hope that gives everyone some more hope than in solving and approaching the poly crisis. With every value chain, there is a different cast of key actors who comprise the policy landscape in which, of course, your research might be relevant. And it behooves one to be aware of the dynamics on that landscape. To illustrate, I'll vastly oversimplify here and just note a couple of the many key actors involved in antibiotic discharge limits from pharmaceutical manufacturing, one of the three key economic sector value chains. In the stakeholder quadrant diagram on the right-hand side, we might array, of course, key actors based on whether they are in favor of the position we're taking to limit antibiotic discharge from pharmaceutical manufacturing. They're like the advocates and supporters on the right side, or whether they are influential in the policy decision taken, blockers and advocates to the top of course, the diagram. Of course, in our class, when we teach this, of course, we actually always ask our public health students to figure out how do you move these actors from quadrant to quadrant. That's where the analysis really begins. But let me just start with a more straightforward look at this particular situation. We might well imagine that pharmaceutical manufacturers might resist the additional costs of complying with antibiotic discharge limits, that they might be particularly concerned if they have small margins in producing these antibiotics, which certainly by comparison to oncology drugs or cancer drugs, they do have much lower margins. So we might place them as the purple dot, as potential blockers to such a policy. And similarly, one might place public interest, civil society groups in the upper right-hand quadrant as advocates of these regulatory efforts. And you can see these now in the purple and the green dots, respectively. But imagine my surprise, of course, when one of these pharmaceutical manufacturers stood up to argue for stricter limits on antibiotic discharges at the policy briefing that we had organized with the UN Secretary General's office in New York City in 2016 in lead up to the UNGA meeting in that year. And then again, a year later, at the UN High-Level Political Forum, the same message from this group. And so you might have to ask yourself, in fact, whether or not you got your analysis right. And in fact, it turned out that manufacturer, which is a multinational one, might have had a different perspective than the rest. A pharmaceutical manufacturer might seek to promote, of course, its status as a sustainable antibiotic producer as part of social responsibility. Or it might reasonably recognize that unchecked antibiotic emissions threatens, of course, the antibiotic industry, leading to a shorter market life for antibiotics. But it also might provide strategic advantage over competitors less well-positioned to reduce antibiotic pollution, an advantage that might carry over in the procurement tenders, that give preference to the pharmaceutical companies that have the ability to take on, of course, this challenge of antibiotic waste. So this, of course, suggests and explains why pharmaceutical manufacturers are not a homogeneous stakeholder group, but one likely divided across both quadrants of blockers and advocates. Now, the same, of course, analysis can unfold, of course, for civil society. And if you can actually take a look and see, and you can see policy tensions in the civil society landscape, and we saw this within the Antibiotic Resistance Coalition up front and close, where in fact some of the NGOs were, of course, focused on environment, and they were concerned, of course, on such discharges, and others were, of course, health NGOs from the innovation access community, to which, of course, we were seeking important alliance. And their tensions, of course, were, of course, quite differently grounded. Over the past decade, for example, we have actually seen, as access to medicines groups have, an uneven supply of benzene penicillin G, or BPG, an older antibiotic that has been the mainstay for secondary prophylaxis of rheumatic heart disease, for rheumatic heart disease, and there are about 30+ million people so at risk. Shortages of this antibiotic have made it even difficult for UNICEF to stock its emergency kits for treating pregnant women with syphilis. For secondary prophylaxis of rheumatic heart disease, people have to receive typically a somewhat painful intramuscular injection every 3 to 4 weeks, sometimes for periods of up to a decade. And apart from shortages, the powdered formulation sometimes doesn't dissolve well and causes needle blockages. An aqueous formulation, though, costs 100 times more and requires a cold chain. And though some of us had proposed that we ought to have a project to really reformulate this into a longer-lasting depot formulation, that idea has not moved in years. Much of this shortage can be traced to the failure of some manufacturers, such as in China, to maintain GMP standards in its production of benzene penicillin G. So any additional requirements that might burden the fragile supply chain to the largely low and middle income country market that requires BPG raises concerns about disrupting further access to that antibiotic. And that is the reason why the civil society movement was not necessarily on the same page. But of note, in recent years also, this, of course, challenge has moved north, to the global north. There have been shortages of amoxicillin that have extended to high-income country markets, from the United States to the United Kingdom. And this has rekindled, of course, discussions of reshoring the production of essential drugs so that they are locally produced to ensure greater national health security. These kinds of dynamics complicate, of course, the landscape significantly. Let's consider what the window of opportunity for advancing policy change might be. The Overton window represents the range of policy ideas that actually might be deemed politically feasible for policymakers to pursue. Over time, the Overton window can shift or expand. There is no fixed ordering to the range of policy approaches that might be applied, and I'm not implying that necessarily this order is the right one. Domestic government regulation might kick in, of course, earlier, depending on how they are concretely implemented. And similarly, GMP requirements on manufacturing facilities matter quite differently if they are part of the WHO pre-qualification process in order to actually bid on a UNICEF tender, or whether they're just part of a domestic country's requirement. But the kind of research that, for example, defines predicted no-effect concentrations has enabled the beginning to setting of some of the drug-specific targets, based either on some measure of ecotoxicologic effect or on the likelihood of reducing resistance, or both. The possibility of setting targets has allowed the industry to move forward, seeking voluntary standards rather than mandatory ones. The Access to Medicines Foundation took a deeper look at the implementation of this and found, of course, many more challenges. That, in fact, a lot of the top tier, of course, companies that you might name, actually they have very little reach through to the contracted subsidiaries or actually contracted manufacturing facilities, which actually where that antibiotic pollution occurs. Now, and the British Standards Institution, of course, recently launched its independent verification of compliance in conjunction with the AMR Industry Alliance's antibiotic manufacturing standard. But one might ask quite fairly if relying on the industry to self-regulate poses any concerns. So the Overton window actually might well be extended based both on political and technical considerations. A local pilot in Norway actually suggests potential promise actually in sourcing and influencing suppliers to undertake changes in their manufacturing practices by counting as part of their essentially procurement tenders some weight to the production practices that are not as polluting. And new facilities actually might emerge actually in new partnerships. GARD-P, one of the product development partnerships dedicated to bringing novel antibiotics to market for low and middle income countries, has partnered with Shionogi, a Japanese manufacturer that has made available cefiderocol in a way that actually they would scale up local manufacturing through licensing from Shionogi. This kind of partnership, of course, could be shaped in a way when the licenses are put forward, and I think this has been discussed in this particular partnership, that in fact the manufacturing effluent, the antibiotic pollution that comes from the scale-up plants could be conditioned as part of course, the licensing actually contract. Now, these may be stepping stones that widen the Overton window, such that a pooled procurement facility like UNICEF or PAHO Strategic Fund, or the newly proposed facility to buy antibiotics from multiple low and middle income countries, the SECURE initiative, the WHO and GARDP have been advancing to ensure stable demand and surety of returns to manufacturers. They might adopt these kinds of requirements over time. But another approach would be lowering the technological cost of complying. And this might be done through research breakthroughs in the technology in reducing antibiotic pollution, which many of you might be able to actually contribute towards. Government subsidies to provide the capital in making such improvements. Offering a preferentially higher price in procurement tenders to offset the cost of complying with these standards. And in fact, UNICEF does just this in order to ensure they have a 15% actually window to ensure actually that procurement supply is not taken by just predatory pricing of a particular supplier, but in fact diversified across a more robust set of suppliers. The same principle can be applied in this kind of setting as well. How you overcome, of course, the technological cost of complying could also reassure those access to medicines NGOs that are really more focused on the possibility of jeopardizing a fragile supply chain, because for them, the bottom line is delivering affordable antibiotics to those in need in developing countries. The recent work, of course, on WHO's guidance on good manufacturing practices that Joachim Larsen actually had mentioned is a great example of how we also might see soon a shift in this Overton window. Now, stepping back and thinking about how actually some movements are already taking advantage of value chain outside of the environmental movement, but also closely related. And we can look to the agri-food sector for such inspiration. Civil society groups, in fact, have used this approach from the Keep Antibiotics Working Coalition. I believe Lance's group actually has also been involved with this group, have influenced the work of food procurement so that those buying for restaurant chains or grocery stores would do so responsibly and insist that the food animal products that are sourced are raised without the routine use of antibiotics. And beginning in 2015, these groups actually issued the chain reaction report, initially calling upon the top 25 restaurant food chains in the country to do just that for poultry. And over the first 3 years of the consumer report card, they first prompted 5, then 9, then 14 of these top restaurant chains in the United States, accounting for 2/3 of the fast food industry revenue in the country, to take steps to limit antibiotics in their supply chain. Now, this strategy does not rely on government alone, but rather, in fact, targeted public-facing brands at the distal end of the supply chain with the insight that food buyers could prompt the changes upstream in the production practices of groups like Tyson and Purdue. Now, we brought the Antibiotic Resistance, through the Antibiotic Resistance Coalition, we brought the groups from the United States together with groups in Asia. And soon to follow, the Center for Science and Environment in India would go on to put out its double standards report, flagging that the timetable for removing antibiotics from these food franchise supply chains in the United States was not being extended to, of course, those outlets in India. And so they called out the double standard as a way of raising awareness to this issue. In the United Kingdom, the Alliance to Save Our Antibiotics put out a consumer report card on UK grocery store chains, both on their products that, in fact, are their own branded products, as well as those stocked from other producers. And by the third iteration of their supermarket report, all 10 actually supermarkets had policies banning routine prophylactic use of antibiotics for some of their products. Food suppliers, of course, are responding themselves as well to this effort. You can see that in organic certification. You can see that also in efforts like in Ecuador, where the leading shrimp producers in that country have banded together to create the Sustainable Shrimp Partnership and create a blockchain verification for zero antibiotic use for at least a subset of their shrimp farms at this time, in combination with other, of course, sustainable practices. It's got a long way to go because their market share is still small and they need to create a premium market. But these are the market dynamics, the value chain. Importantly, of course, some of you are thinking that a value chain probably is quite remote from my benchtop, and while Vannevar Bush actually, of course, suggested a strong divide between basic and applied research, the late Donald Stokes, I think, gave us pause to consider that, in fact, maybe that divide is not such a hermetic, divide between the two. And he did so in his class of work, the Pasteurist Quadrant. We are currently carrying out work with the WHO and the UN Development Program and the Global Health Innovation Technology Fund to envision what would be involved in rethinking how we might strengthen LMIC R&D systems. And in this work, the boundaries may be even fuzzier, actually, between basic and applied sciences when we try to make R&D systems more fit for purpose. That is, design a system to generate research for social use. Now, importantly, of course, this brand of science research actually might also leapfrog in taking us to continuous quality improvement, to implementation research, to participatory approaches to research that more directly involve healthcare workers and even communities and citizen scientists. New point-of-care diagnostics, of course, can also extend the range of our research efforts and to whom we touch and how we connect with community, particularly with the advances and advent of information technology and artificial intelligence. Our ability to engage, a much larger community in our work is at hand. Some of these diagnostic and monitoring tools might become tomorrow's accountability technologies. And importantly, I would point to the 3 C's in this. One would be, in fact, collect, comprehend, and compel. Collect through new point-of-care diagnostics or other tools, comprehend by, of course, using the crowdsourced data to make findings transparent, and compel by making the transparency of these data in scorecards and other measures of accountability. And importantly, although we may not actually have a systems approach to stop war, Médecins Sans Frontières has done, of course, this kind of work within conflict-ridden areas. You can see on the left, Antibiotic, which is their CE-approved, in fact, mobile app to enable those places where don't have microbiology-trained technicians to read antimicrobial susceptibility tests. And on the right, on the hardware side, they've actually developed a mini lab that can be set up in 2 to 3 days. Training takes longer, but to actually conduct bacteriology testing in these kinds of areas. And you may not work in conflict-ridden areas, or at least not the military kind. But imagine if we could equip citizen groups with tools that could spot drug-resistant pathogens on one's grocery store shelves. How could we make that latent signal into a policy visible one? Now, beyond the 3 value chains of pharmaceutical manufacturing, healthcare delivery, and agri-food, we also have a lot of research here at EDAR7 that may spur new policy connections. I will just quickly point to a few. One, consider the work on herbicides, particularly on glyphosate or Roundup, 2,4-D, and dicamba that could affect tolerance to antibiotics. While it could go in either direction, worrisomely can induce perhaps greater drug resistance in enteric bacteria like E. coli. And AMR also interacts with another, of course, environmental pollutant, microplastics, which several, of course, posters highlighted at this meeting. And, of course, microplastics, which seem nearly ubiquitous in our food, in us, and around us. Microplastics, of course, that form biofilms on their surface may increase by 100-fold the uptake of genetic exchange of drug-resistant determinants. And such connections can bridge to new coalitions and offer potential co-benefits with other environmental movements. Now, of the environmental movements, of course, that has perhaps the greatest sway today, climate change is perhaps paramount, and not unjustifiably. But AMR right now is of course, just one of a long list of potential consequences to mitigate, from the submerging of coastal cities and island countries to the widening belt of drought-stricken agricultural economies. But what if we could change the direction of the causal arrow? And while not definitive, there was research in 2016 that looked at the effect of a 3-day course of tetracycline and found that in cattle, treated with this antibiotic, methane gas emissions were 1.8 times greater. Now, other studies, of course, show this is a much more complicated picture, but if treating livestock with antibiotics contributes to anywhere close to 1.8 times more methane gas emissions, figuring out that would be a game changer, given agriculture's potential contribution to climate change. Should we be looking for these causal linkages that might place the use of antimicrobials much closer to the front of the line in the fight to slow climate change? Let me now turn to the UN high-level political declaration, which is, of course, coming up this September. And Barbados and Malta have led, of course, the consultation process with a multi-stakeholder hearing actually in New York in mid-May. If you could afford to actually get there, then you were represented perhaps at the table there. But the high-level political declaration, as you can see on the left here, actually has a number, of course, of provisions around environment. They're all very, very high level. And on the right, you can see actually a number, of course, of targets. All those targets that you can see here, actually, and I won't go into the detail in the interest of time, in many ways, actually, this process is being wrapped up in some ways, right? In the sense that, yes, we could actually debate an additional, perhaps, metric or two, but much of this is written as in the zero draft. So the real question, actually, for our community, I think, is in part, how do we prepare for the day after, actually, the UNGA high-level meeting on AMR? Important, of course, guide rails to actually what we might do are in, of course, the UNGA HLM process. But importantly, it's really much of the work about what follows on the next day. And we've talked a bit about, actually, and I will probably go quickly over this, that part of this is determined by the type of targets and the type of measures that you have in place. One of the things that we've discovered, of course, that was quite interesting a few years back was we lifted up one of the figures, actually, in the TRACK survey, which, in fact, monitors country self-reports on AMR progress. And we found, not surprisingly, that only 1 in 5 countries had identified funding for their national action plans, and nearly 40% of countries did not have a budget operational plan for AMR. Now, unfortunately, though, in the year afterwards, after we pointed this out, they changed the instrument. You can see it through the cross marks. And as a result, they eliminated, actually, the possibility, actually, of tracking this. After, of course, many people, I think, raised this concern, we particularly, they actually restored it. And so we do know today, actually, that in fact they have, and they're using it now much more effectively, actually, in lead up to UNGA HOM, which is that 11% only have dedicated financing to implementation and monitoring of these. And at the country level, these budgets, for these budgets to be real, countries need to be able to prioritize where to invest to make AMR, the difference in AMR. Where might co-benefits be realized? And is there synergy with pandemic preparedness, prevention, and response? Now, similarly, and I won't go into this much because, again, in the interest of time, the mobilizing for an AMR-specific indicator actually was also a major challenge. At the beginning of the SDG process, there was no indicator that's AMR-specific. But midway through, you can actually advance possible alternative indicators, but it's a competitive process, one in, one out. And so a number of indicators were put forward, eventually actually backing the WHO indicator, and actually one of my colleagues helped put together actually the graphic in the middle, Pratik Sharma, and they were able to actually, with that backing, more civil society comments came in on the AMR-specific indicator than any other indicator, even the maternal and child health ones. And so it became adopted. But we wanted more than stewardship, because importantly, you can't just ask countries to document stewardship and not ask them whether they have access to antibiotics. And so, importantly, we made the ask, and they are measuring now by repurposing an existing indicator, the basket of goods, actually, the basket of rather drugs, in a way that actually captures the access dimension as well. Now, how do we bring all of this together? Universal healthcare and actually AMR is one sort of opportunity. And you heard actually a couple days ago, that in fact there was, and in fact the WHO's efforts are building upon the OECD's effort in a really important work that was, I think, really recognized for a number of years, called Stemming the Superbug Tide, Just a Few Dollars More, where they proposed a comprehensive AMR package. And importantly, you can see that just investing $2 per capita per year in a comprehensive package could actually tackle AMR, would have averted 47,000 deaths in OECD countries. It would have, in fact, also saved $4.8 billion a year and pay for itself in under a year. And environment is part of that package. What's not part of that package is new antibiotics, which is the major focus of financing efforts, of course, on both sides of the Atlantic. And so in many of these countries, we need to think about actually how do we actually create a situation where the approach to AMR reflects the opportunity costs it places actually on our systems. Finally, it's important to keep in mind that even before the pandemic, the World Bank projected that if AMR went unchecked, up to 24 million more people could be forced into extreme poverty by 2030. It looks like COVID-19 has beaten us to the punch there. But under the high-impact AMR scenario, this could amount to 3.8% loss of annual GDP by 2050 and an annual shortfall of 3.4 trillion by 2030. Now, the bank said that putting resources actually into AMR containment now is one of the highest yielding investments that countries can make. By investing just $9 billion a year in low and middle income countries, we could avert trillions of dollars of potential economic losses. And significant returns on this investment would accrue importantly, as you can see on the graph on the right. Over 80% of these returns of investments in low and middle income countries, in fact, would benefit upper middle and high-income countries, probably through trade and other aspects, through the very countries that are best positioned to make this global investment. And we heard earlier this week, of course, Chantal Morel's very important analysis that's now supporting the Global Leaders Group actually call for efforts to recognize that if we put $46 billion, a much higher number, actually forward, that we could actually generate $7 to $13 of returns for every dollar invested by 2050. Yet policymakers didn't buy it even at $9 billion when the price tag was put forward. So the question is, how do we get to $46 billion? That's a lot to swallow. The Multi-Partner Trust Fund on AMR, 5 years of efforts, $30 million roughly in the ballpark of has been raised. That is not even a rounding error in actually the response to COVID-19. So how do we get a theory change to move from A to B? And taking a page from the OECD's original report, we might call for a specific per capita actually package amount at $2 per capita that would cover the hoped-for package of any country and by every country. And as such, it could be marketed as a social vaccine to actually address AMR, much as we buy polio vaccine doses for an immunization campaign. And secondly, as some of you well know within this sector, the UN report actually documented that nearly 90% of the $450 billion a year that we spend on global farm subsidies were harmful to the health, environment, and the climate, as well as worsening inequality by excluding smallholder farmers. We should look to repurpose such actually financing and find co-benefits as we look to invest in the future of AMR. So I hope this actually offers a systems perspective on the challenges and opportunities ahead for integrating the environmental dimensions of AMR into policymaking and for leveraging your research to shift or expand the Overton window for change. May you turn polycrises into policy windows of opportunity. To do so, one can see that we will need the help of the EDAR community to wade through the complexity to reach, as Oliver Wendell Holmes described it, the simplicity on the other side of complexity. Thank you for the opportunity of learning from you all this past week and to share these reflections as you bring forward the reports from the workshops.
Hi, I'm Luis Motabrao from the University of California, Irvine. Thank you for your great talk. So in all these approaches that I see, systems approaches, the part that I see missing is understanding the root of the problem. And the root of the problem is an evolutionary problem. So during 80 years, we have been producing new antibiotics, just waiting passively to get a new antibiotic resistant gene to be incorporated into a multi-drug resistant pathogen that kills people. So that cycle keeps going over and over and over. And behind that, there is an evolutionary process where transposases are capturing antibiotic resistant genes from the huge pool that exists on the planet. They are putting them in conjugational and conjugative plasmids that now they move freely everywhere. Now, that I just explained very, very simply, of course, it's a very complicated process. And so there is no research agenda to understand this process that is at the back of our huge antibiotic resistant problem. So I wonder, what are your thoughts in terms of developing an agenda to understand the basic evolutionary process that is going on? And of course, this is way beyond the clinic because these antibiotic resistant genes are everywhere, and particularly in the commensal flora.
Mm-hmm. Now, I think it's a great actually observation and comment as well. The challenge oftentimes to bridge between policymakers and funders and the research community, where in fact much of this important work's being done, is in some ways also that divide between basic and applied research actually understanding that I think sometimes befuddles actually how we conduct research. I do think, as Don Stokes actually pointed out in his Pastor's Quadrant, we really need to rethink actually that boundary. But that also means a very different dynamic actually of exchange between researchers and policymakers. I pointed out that a bit in the work we did actually for the tobacco control movement in Southeast Asia. tobacco control is not exactly actually a winning issue in a lot of ministries, particularly finance ministries. And part of it, you have to engage actually those policymakers in the research agenda process. You can't explain it to them probably at the genomic level. That probably would not go so well. But you can explain them actually at the more system level. So for example, we actually used modeling, we supported modeling for sim smoke to show what the prevention gains would be, because you can't see them so clearly and immediately in tobacco control. So we need to be able to actually project, actually, through some of our other research work, actually what the possible actually opportunities are, and what are the opportunity costs of not doing this kind of work. I hope that offers some insight, actually, as to what one might undertake.
Thank you.
Thank you so much for your talk today, Anthony. This is Susan Mongroders. I think you mentioned me as the glue. So a lot of people here are benchtop scientists or genomic researchers, and they're really interested in policy but may not know where to start. What recommended reading or what courses may be available? Is there something that they could use from your talk? Could you help them, point them in the right direction?
Yeah, well, I don't want to make a plug, but we actually do have a one-week intensive course, actually, on a lot of the tools that we just discussed. And we actually go through what we call problem and objective trees, SWOT and stakeholder analysis, and then an intensive 3-credit, one-week course, actually, which we have a non-credit option and a subsidy as well in our health systems program for actually these participants. We try to engage, actually, policymakers, and we've had a range from government agencies like Gavi, or intergovernmental, actually, international agencies like Gavi, places like WHO, other places actually like foundations come to actually these courses, as well as development aid agencies and also rank and file researchers. And I think the goal is actually in some ways to try to provide them a quick view of actually some of the way in which we think, which is a little bit different sometimes, I imagine. Our vernacular is a little bit different. I'm trying to understand all the vernacular here, but I assume it's a little bit easier to understand my vernacular because you all live in this larger political economy of the world. But still, we can teach actually more formally some of these issues. And again, the course starts actually on Monday. People can still sign up because the school does not stop enrollment. So if anyone wants to know more about it, feel free, of course, to reach out to me.
Oh, yeah. One little last question.
Thanks very much for your talk. I was wondering, because sometimes we've even seen on national levels that you can have a very strong diversity, for example, an AMR between communities, rural and urban. So how do you go from this very, very global approach to local specific kind of therapies for what needs to be done?
Yeah. So I think part of the challenge, of course, is to figure out when we put forward a target, or when we put forward actually a recommended practice, that we consider actually how it tiers across the different kind of resource settings. We do this at the global levels. We've argued for doing this at the global level more so. This is why I have some problem with these global targets sometimes, is that they don't translate particularly well to who's going to do the work to get to those targets. And the reality is actually in some areas, a disproportionate amount of the burden actually should fall upon those who are the greatest users actually of antimicrobials. Yet you will seldom see some of these countries actually called out, which includes the United States, China, and others, but they actually literally constitute the majority in the world. Then taking it down, of course, to the national level and the local level, a similar principle actually of, and I think perhaps in this audience one can think about common but differentiated responsibilities, but that's actually not actually being very, very well received actually on the international diplomatic scene, in part because it's not coming with resources. So mandates without resources is like asking people actually to do something that resets their priorities, and you're not then where they are at. And so oftentimes when we talk about AMR in some of the poorest areas of the world, they sort of say, well, I've got some other priorities going on here, like food, malnutrition, and other actually problems, making it to the next actually, of course, paycheck. So these things have to be considered actually as to how you actually do this work, and important the tools you bring to it, because you can change actually the nature actually of the tools we use to collect things. They don't always have to be the latest and greatest, and there are ways in which actually I think to actually go part way to actually make sure that you are with them actually in the journey together. I hope that helps.
Thank you so much.
My pleasure.